These are my disclosures. Nothing really pertains to that for that presentation particularly. So when we think about what do we do for diagnosis and staging? Well, mammography and DBT nowadays and ultrasound are still the primary diagnostic tools we have for staging our patients. What do we want to tell our surgeons? Well, what is the size of the tumor? Is it unifocal, multifocal? What is the lymph node status? And also, in particular, if the patient is going for neoadjuvant chemotherapy, which a large proportion of patients actually is currently going to, and also with neoendocrine treatment pushing into the realm, is the clip actually appropriate? Because the intent is when the patient responds, you want to be able to offer the patient breast conservation afterwards, and you will still have to do a surgery. So we want to know, is the clip in the right position or for planning the surgery in the end? So when you look at that, I mean, that is pretty simple. In this case, do we need an MRI? I personally would think, no, not really. This is a unifocal lesion, which is well visible on ultrasound and mammography. So we can really do well with that. Yeah, so same case here. After neoadjuvant chemotherapy, that is the reason why we really need to know where the clip is. This lesion is gone, yeah, but I still will have to localize something to offer my patient breast conservation and an assessment, how was the response. So the problem with mammography and sonography is they can underestimate lesion extent. And also, if the patient is not such an easy case with a non-dense breast where I can see the tumor easily, then it gets a little bit more tricky, and surgery planning can be difficult and can also result in the end of the day in unnecessary, or not unnecessary, the revision surgery is necessary, but it would have accurate planning beforehand would have obviated positive margins. And I mean, I think in this case, it can be really clear why we are particularly limited in women with dense breasts. In this breast, I don't even know if the woman has a cancer or not. This is like, yes, a wild guess. In screening, I probably would say this is a normal exam, and still there can be a massive cancer in there. So for staging, and I mean, these are the easy cases. I have a thing for medical paintings and medical stuff. So here we see two images where actually the cancer is actually visible from the outside, but often this is not the case. So in this case, this is a patient, I can already confidently tell you she has a cancer. So where would that be, in your opinion? Who's for the right side? Left side? Well, in MRI, it's pretty visible that this patient has a massive cancer, which I wouldn't have seen to start with the mammogram. So, and this is where MRI can really, really add something. This is another case. The woman has an extremely dense breast when the hint at the side is already what is going on in the axilla. When we go back, we can say, well, the nodes are here way more prominent. This is actually how she actually found her cancer. She palpated something in the axilla.
Hello. In this talk, I will be discussing with you the diagnosis of common and rare syndromic condition in the first trimester of pregnancy. In general, when we perform a comprehensive first trimester screening, we will not only focus on the nuchal translucency, but mainly on getting images of different organs from the head, the face, the limbs, the heart, and the kidneys, and the spine, and so on. And this is the first step in order to discover any abnormality from the norm. So any anomaly detected could be the first hint, it could be a sentinel sign for a syndromic condition. So, but there are, however, some of typical striating findings, which may be the leading sign, like, let's say, thickened nuchal translucency, or, for example, the detection of an hollow prosencephaly, which shows a straightforward direction to one or another syndrome, and by far more rarely, a condition like radius aplasia. But what are the typical anomalies detected from the point of view of syndromes? And these are the so-called big five: the trisomy 21, 18, 13, Turner, and diploidy. And these are the usual suspects. And these are, let's say, what are called the common syndromic conditions. I will not discuss this further in my talk. It should be another talk separately, because this fills already alone half an hour time. But what is more interesting is when patients come at 22 weeks and the child has malformation, they ask you, and this is almost every day, there are the typical questions asked. One question is, why did this happen? Then a common question is, did we something wrong, my husband and me? Or why was not seen earlier? Sometimes they say, okay, if there is there's one single chamber in the heart, or let's say radius aplasia, why it was not seen earlier? And then the question is, in the next pregnancy, how early can you tell me there is no recurrence? This is why, let's say, the genetic setup may be of big importance, because for some patients, they know at the end it was a monogenic disease with autosomal dominant inheritance.
Okay, so for the next 30 minutes, I want to share with you some real cases that we had in our practice. I focused this primarily on cases that we had in pregnancy. I added a couple that I think I wanted to highlight some forms of adnexal masses. So there is a free online ultrasound book that is available. I would strongly recommend that you download it. It is from the website openultrasound.com that you see up there. It has been translated in almost 11 languages and downloaded close to 100,000 times online. It is free. It has a lot of the information. It has OB and GYN in it. And in the GYN section, there's a couple of chapters on adnexal masses that highlights a lot of the characteristics of what I will be talking about. So 25-year-old referred with left pelvic pain. That's an ultrasound of the left adnexa. So next step, if I ask you, you will say, I want to add color Doppler to this. So that's a very important aspect. You need to assess whether there is blood flow within the adnexal mass that you're looking at or not. If you suspect this as a hemorrhagic cyst, or a hemorrhagic corpus luteum, which should be your first instinct, then you should not have any blood flow inside on color Doppler. This is artifact here, and you see there's no vascular signals inside. There's excellent sound transmission here, and you can see the capsule all the way around. Now, when you put color Doppler looking for the presence of flow within an adnexal mass, make sure that your velocity scale is low, because you're looking at capillary flow. So it should be between 5 and 10 centimeters per second. Your gain should be maximized. So what I do is I turn the color gain until it floods the image, and then I retract a little bit and make sure that your filters are all the way low. These are very important characteristics in assessing adnexal masses with color Doppler. So this is a classic hemorrhagic cyst. Typically, what happens if you bring this patient back, you will see that the clot starts to retract, as you see right here, part of its resolution, and over time it will go away, over maybe a month or two and so on.